Good evening. The topic today will be the management of psoriasis patients with comorbidities. Next slide, please. First of all, I'd like to present where I'm coming from. So I'm chairman of the Department of Dermatology in Toulouse, France. Toulouse is a large city which is located in the southwest of France, and Toulouse is famous for the Airbus industry, also for the capital, and this is where I work, which is the Larrey Hospital, where the Department of Dermatology is a reference center for the Midi-Pyrénées region, which is a region of about 3 million people. We have a large psoriasis clinic with more than 1,500 patients on systemic treatment and biologicals, and we have about 200 patients in clinical trials for psoriasis. On this slide you have my conflicts of interest. So, of course, I'm investigator and consultant for several pharmaceutical companies developing drugs in psoriasis, but I have no patent and no stock options related to these compounds. Next slide. And this is the agenda of the presentation. We will discuss today the issues with clinical trials in psoriasis, because as you will see, many patients with comorbidities are excluded from clinical trials. Then we will review what the psoriasis treatment guidelines tell us about how to treat patients with comorbidities. And of course, we will review the impact of comorbidities on psoriasis treatment and how we need to factor in this point when we select a treatment for patients. And last, we will discuss the elements for future consideration, how we could improve in the future the tailoring of psoriasis treatment for patients with comorbidities. So there are many comorbidities which affect treatment choice in psoriasis. One of them is weight. You know that obesity, and we will see that in the next slides, has a high impact on treatment efficacy and can also have an impact on treatment safety. Age also is an important component because, of course, patients with higher age, over 65-year-old, have safety issues which need to be taken into account. Alcohol consumption, depression, anxiety are comorbidities which can also affect treatment choice. Cancer, cardiovascular disease, the presence of chronic infection, like for example hepatitis B, hepatitis C, will determine the choice of treatment in psoriasis patients. And of course, liver disease and kidney disease can affect the metabolism of drugs and can also influence treatment choice. Next slide. Unfortunately, when you look at the clinical trials, many clinical trials exclude patients who have comorbidities. And this is not in accordance with the guidelines. On this slide, you have the ICH guidelines and the FDA guidelines, which are supposed to guide pharmaceutical companies when they develop drugs for patients. And the guidelines clearly say that studies, especially in phase 3, are designed to confirm the preliminary evidence accumulated in phase 2 that a drug is effective and safe for use in the intended indication and recipient population, which means that in phase 3 clinical trials it is important to include patients who belong to the population which will benefit from the drug, which means that literally in these studies you need to include patients who have comorbidities, because many of our psoriasis patients have comorbidities. And the FDA guidelines state that broadening inclusion criteria in phase 3 enhances the generalizability of the safety and the efficacy findings. And you will see in the next slide that unfortunately what we see is that many patients with comorbidities are excluded from phase 3 clinical trials. On these slides we have an example of the main exclusion criteria which are adopted in clinical trials. And we record more than 20 exclusion criteria in phase 3 studies nowadays. In some studies, elderly patients, age over 75, are excluded. In some studies, patients with recurrent and chronic infections, any antibiotic use are excluded from clinical trials. More broadly, in some studies, patients with any systemic and significant uncontrolled disease, renal failure, hypertension, liver disease, diabetes. You see the very, very broad exclusion criteria here. Of course, patients who have a history of hepatitis B and C also are excluded from clinical trials, patients with a history of cancer, patients with excessive alcohol consumptions, etc., etc. So in summary, what we see is that the phase 3 study population exclude many patients from clinical trials, which prevents us from having a good efficacy and safety evaluation in this population. Next slide. So on this slide, you can see that the main question we have is that the patients from clinical trials are mostly the healthy patients. And the patients we see in our daily clinic are patients mostly with comorbidities, weight problems, cardiovascular problems, alcohol consumptions. And it's very difficult to translate the findings from clinical trials which are made in this healthy patient population to the patients who have comorbidities, because it's a different population and it's difficult to extrapolate. Next slide. Let's look at the treatment guidelines. If you look at the treatment guidelines which are published in the literature, many treatment guidelines actually provide very few informations about how we need to treat patients with comorbidities. And this is not surprising. This is not surprising because these psoriasis guidelines are based on the phase 3 registration trials which are performed for approval of a drug, and they do not include any information about patients with comorbidities because these patients are excluded from the trials. Fortunately, we can say now in 2014 that the future European guidelines, which are to be published in 2015, will include data about how to choose the right treatment for patients with comorbidities. And this is based on the experience which has been accumulated in the last 5 years on treating patients with comorbidities with psoriasis, systemic agents, and also biologicals. Next slide. This slide reports on a very important paper which was published by the group of Ignacio Garcia Dorval, a Spanish group, in the Archives of Dermatology in 2012. So the authors looked at the Spanish psoriasis registry of patients. They identified 1,042 patients from this registry. And they asked the following scientific questions. Let's look at the patients who are treated with systemic agent and biologicals. And let's compare the safety of a drug in patients who have comorbidities, who are not eligible for clinical trials, and in the patients who don't have comorbidities. And they found first that one-third of patients in the registry actually would have been not eligible for clinical trials. And when they look at the safety of biological agents and systemic agents in this specific population of patients, they found that patients who had comorbidities had a higher risk of serious adverse events. And among the factors which were significant, older age, over 70-year-old, was associated with a higher risk of serious adverse events. And also a history of cancer was associated with a fifth-fold increase in the risk of serious adverse events. So in other words, when you look at patients who have comorbidities, these patients have a higher risk of experiencing a serious adverse event with drug. Next slide. Let's look first at obesity. Next slide. Obesity is more prevalent in psoriasis than in the general population. This has been shown by several clinical studies. In this study, which was performed by Nicolas Meyer from our group in the French patient registry, he looked at the prevalence of obesity in patients with mild psoriasis and in patients with severe psoriasis. And as you can see on the slide, patients with severe psoriasis have a threefold increase in the risk of obesity. So obesity is associated with psoriasis, and obesity is associated with severe psoriasis. Next slide, please. So what is the effect on patient weight on treatment outcome in psoriasis? So it has recently been demonstrated by Jensen's group that a low-calorie diet will improve psoriasis severity. They performed a randomized control trial in which they compared a low-calorie diet versus a normal diet. And they found that a low-energy diet, 800 to 1,200 calories per day, was associated with an improvement in psoriasis. Gisondi in 2008 showed that cyclosporine in combination with low energy diet was associated with a better improvement in psoriasis as compared to cyclosporine alone. It has been shown also that the therapeutic response to most systemic agents and biologicals was better in patients with lower weight. And also for some agents, the adverse events are higher in patients who are obese. Next slide. On this table, you have the data regarding the response to adalimumab. Adalimumab is an anti-TNF antibody, and Louis Puig in this paper compared in the different trials the response to adalimumab in patients who had a lower weight versus patients who had a higher weight. And they divided the weight of patients in the trials into quartiles. And as you can see on this slide, if you look at PGA or PASI 75, there are many more patients who respond to adalimumab in the lower weight quartile as compared to the higher weight quartile. And if you look specifically at the Champion trial, which was a comparison between placebo, adalimumab, and methotrexate, the response to methotrexate is better in patients who have a lower weight. 64% of patients achieve PASI 75 in the lower quartile, whereas only 37% of patients achieved PASI 75 in the higher quartile with methotrexate. And clearly from this slide you can see that in patients with higher weight, patients who are really obese, you need to increase the dose of most therapeutic agents to reach the same outcome as in lower weighted patients. Next slide. On this table, I've tried to indicate for each agent, first, the evidence we have regarding the effect of dose related to weight, and also the impact of weight on the safety of the agent. So for methotrexate, we have limited evidence that weight has an effect on response, and we have limited evidence also to say that if you increase the dose, you can increase the therapeutic response. And this is simply due to the fact that there is no good dose-finding study with methotrexate, because methotrexate was developed in the 1950s, where there was no formal dose-finding study performed. For cyclosporine, we have substantial evidence that increasing the dose according to weight is increasing the response. And this is the reason why cyclosporine is dosed per body weight. We have also evidence for cyclosporine that if you increase the dose in obese patients, you will also increase the nephrotoxicity. That's why it is recommended to dose cyclosporine not according to the real weight of the patient, but according to the ideal weight of the patients. For infliximab, there is also substantial evidence that dose has to be increased in obese patients. And this is the reason why infliximab is dosed per body weight. For adalimumab, there is limited evidence that increasing the dose is needed in obese patients. It's off-label, but clearly we know that there is a better response in lower weight patients. For etanercept, there is also limited evidence that you can increase the dose in obese patients and you will improve the response. But there is also evidence that there is a better response to etanercept in lower weight patients. For ustekinumab, there is substantial evidence that obese patients need a higher dose. It is in the SMPC. And also in patients with lower weight, we demonstrated in the transit study, which was published this year, that increase from 45 mg to 90 mg in the dose of ustekinumab was associated with a gain in PASI 75 in 40 to 50% of the patients who initially did not respond to the lower dose. Next slide. So I think I've tried to convince you here that it is important in patients who are obese to take the appropriate measures to control obesity or to prevent weight gain in these patients. And it has been shown also that controlling and improving obesity in these patients would improve the therapeutic response not only to systemic agents but also to biological agents. Next slide. Now let's look at cardiovascular disease. Next slide. Cardiovascular disease is very prevalent in psoriasis. In this slide, you have the results of the systematic review and meta-analysis by Caroline Oro that she published last year in the Journal of the European Academy of Dermatology. In this study, we tried to estimate in a meta-analysis if psoriasis was associated with an increased risk of cardiovascular events. So as you see on the slide, psoriasis is associated with an increased risk of coronary heart disease. The relative risk is 1.3, so it's a 30% increase in the risk. Psoriasis is associated also with an increased risk of myocardial infarction. The increased risk is 25%. the increased risk of stroke was not significant in cohort studies. It was slightly increased in cross-sectional study. So in summary, there is an increased risk of cardiovascular events in psoriasis, mainly myocardial infarction and coronary heart disease. Next slide. What does it mean for the patients? Actually, on this slide, Erwin Armstrong tried to estimate the burden of this increased risk at the level of the population. And as you can see, he calculated on the left column, no, on the right column, sorry, the number of excess cases of myocardial infarction which were attributed to psoriasis. And for myocardial infarction, in the US population, psoriasis would account for about 5,000 more myocardial infarction due to the specific risk of cardiovascular events due to psoriasis. Next slide. We know also, and this has been shown by Sori Après, who did 4 years ago in the department a systematic review about the risk factors for cardiovascular events in psoriasis. We know that psoriasis patients have an increased risk of dyslipidemia, an increased risk of diabetes, an increased risk of hypertension, and an increased incidence of smoking. So in other terms, psoriasis patients have a higher incidence of cardiovascular risk factors, which explain probably why they have a higher incidence of cardiovascular events. Next slide. This slide, which is extracted from a paper by the group of Jim Kruger, shows a very complex relationship between the skin, systemic inflammation, inflammation within the adipose tissue, which probably plays a role, this inflammation, in the cardiovascular risk. But of course, this needs to be further substantiated. Next slide. So what are the key takeaway points from this part of the presentation? First of all, psoriasis is definitely associated with an increased risk of myocardial infarction and to a lesser extent stroke, especially in younger patients with severe psoriasis. Then, the traditional risk factors, smoking, hypertension, diabetes, and dyslipidemia, are more prevalent in psoriasis patients, and they deserve specific measures that the dermatologist can help to install with a general practitioner. And the last point is that obesity is highly associated with psoriasis, with disease severity, with poor disease control, and probably the cytokines which are in the adipocytes will promote systemic inflammation and may contribute to psoriasis severity. Next slide. So what are the practical consequences in patient management? How to manage cardiovascular risk factors in psoriasis patients? This is the first question. The second question being, can psoriasis patient treatment influence the cardiovascular risk? We will see that in the next few slides. And let's start with a clinical case. This is a patient from a department, 67-year-old patient. He's a smoker. He suffers from social isolation and depression. He has, as you can see on the slide, severe psoriasis with 60% body surface area involvement, a PASI of 42, a DLQI of 18. He has hypertension, obesity, high cholesterol, and high triglycerides. Next slide. So this is a question. So what are the significant cardiovascular risk factors in this patient according to the Framingham risk score? You know, the Framingham risk score is a score which is internationally recognized, which helps to assess the risk factors for cardiovascular event in a given patient. You can download the app on Apple Store or Android, and do it easily in your everyday consultation. So what are the cardiovascular risk factors which are significant in these patients? Hypertension, obesity, smoking, hypercholesterolemia, hypertriglyceridemia. The responses are on the next slide. Hypertension, smoking, and hypercholesterolemia are significant risk factors in the Framingham classification. Obesity and hypertriglyceridemia are not significant risk factors. On the next slide, you will have the Framingham risk score. And it is shown here, but you can have it on the app calculated automatically. And Framingham actually takes into account the age, the gender, the systolic blood pressure, the HDL cholesterol, and the total cholesterol. These are the most important points that you need to consider to evaluate the patient cardiovascular risk factor. Next slide. And clearly these risk factors account for the majority of the cardiovascular risk. Next slide. Second question. In these patients, if you want to prevent a fatal cardiovascular event, what would be the most important cardiovascular risk factor to control? Is it obesity with diet? Is it hypercholesterolemia with statins? Is it hypertension with diuretics? Clotting risk with aspirin? Or depression with antidepressants? The response is on the next slide. And the most important cardiovascular risk factor to prevent is hypercholesterolemia with statin. And this is explained in the next slide, where you have the results of a systematic review which shows that the number needed to treat to prevent one major cardiovascular event. And you see that this relates to the hypercholesterolemic studies, which show that to prevent one cardiovascular event with statin, you need to treat less than 50 patients. If you want to prevent one cardiovascular event with aspirin on the other side of the graph, you need to treat more than 400 patients. I mean, the key takeaway point here is that in your patients who have several cardiovascular risk factors and hypercholesterolemia, it's important to send them to the general practitioner to be able to install effective treatment of hypercholesterolemia. Next slide. Second case. It's a 50-year-old farmer from northern France. He's a heavy drinker and smoker. He has neglected hypertension. He has hypercholesterolemia, diabetes, doesn't like to go to the general practitioner. He has severe psoriasis and is intolerant to methotrexate. Next slide. What would be the best psoriasis treatment proposal in this patient? Would that be cyclosporine, acitretin, ustekinumab, etanercept, or adalimumab? The response is on the next slide. Etanercept and adalimumab, of course. Why? Cyclosporine? No, cyclosporine is associated with increased blood pressure and hypercholesterolemia, hypertriglyceridemia. Acitretin is associated with increase in blood lipids. Ustekinumab is a new drug, and there is still controversy regarding an increased risk of cardiovascular events in the first few weeks of treatment. And etanercept and adalimumab are anti-TNF agents, and it has been shown that treatment with anti-TNF agents may be associated with a reduction in the cardiovascular risk. Next slide. On this table, you have the choice of therapeutic agents depending on the cardiovascular risk. On the left-hand side, you have agents which may be associated with an increased cardiovascular risk. This is true for cyclosporine, especially oral steroids as well, and there is still a question mark regarding briacuninumab and ustekinumab. On the middle column, you have the drugs which are associated with a positive effect on the cardiovascular risk. They reduce the cardiovascular risk. This has been shown for methotrexate and TNF inhibitors. On the right-hand side, there are drugs which are associated with an unknown effect on cardiovascular risk, and this is the case for acitretin. Next slide. So what are the treatment strategies in patients who have high cardiovascular risk? The first choice should be methotrexate and TNF antagonist. There should be some caution with ustekinumab, IL-12/23 antagonist, IL-17 antagonist, and acitretin. And cyclosporine needs to be avoided in this patient population. Next slide. Let's look at cancer. What to do with patients who have a history of cancer, and a preliminary question is psoriasis associated with an increased risk of cancer? Next slide. So we will look at the background risk of cancer in psoriasis, we will look at the effect of psoriasis treatment, and then we will discuss treatment strategy in patients who have a history of cancer. Next slide. So this is a systematic review and meta-analysis which was performed by Charlotte Pouplar, who was dermatologist assistant in this department. And she did a systematic literature review between 1980 and 2012. And she assessed more than 1,000 papers in order to perform meta-analysis of studies which showed consistency in cancer assessment methods. Next slide. What she showed is the following. If you look at melanoma, here you have the results of the meta-analysis of all studies, and on the right-hand side you have the point estimate of the meta-analysis. The conclusion is no increased risk of melanoma in psoriasis patients. If you look at squamous cell carcinoma, then if you look at the meta-analysis, the relative risk is 5. So psoriasis patients have a 5-fold increased risk of squamous cell carcinoma as compared to the general population. And this is probably driven mainly by UV light and PUVA therapy. If you look at basal cell carcinoma, the point estimate is 2, which means that psoriasis patients have a 2-fold increase in the risk of basal cell carcinoma. And this is also probably mainly driven by UV light and PUVA. Next slide. If you look at lymphoma, psoriasis patients also have a slightly increased risk of lymphoma, which is 1.4, which is also statistically significant. But pay attention. This may be confounded by the fact that skin lymphoma is sometimes misdiagnosed as psoriasis. Some patients with skin lymphoma are diagnosed as psoriasis for some years, until a point where people do a biopsy and realize the patient didn't have psoriasis, the patient did have skin lymphoma. And this explains why, if you look in these two studies at the risk of skin lymphoma in psoriasis, you come up with very high relative risk. So classification bias may have occurred, which means that T-cell lymphoma, skin T-cell lymphoma patients were misdiagnosed as psoriasis. Next slide. On these slides, we have summarized the cancer which have an increased risk to occur in psoriasis patients. Squamous cell carcinoma, upper aerodigestive tract cancer, liver, lung, pancreas cancer. As you can see here, most of these cancers, which have an increased risk in psoriasis, are cancer which are associated with alcohol and smoking. And this is not surprising because psoriasis patients have a higher prevalence of smokers and heavy drinkers. You can understand why the cancer which is associated with this exposure are increased in psoriasis. Next slide. Let's look at the effect of treatment. It has been shown that cyclosporine was associated with an increased risk of squamous cell carcinoma, that PUVA was associated with an increased risk of basal cell carcinoma, but more importantly, squamous cell carcinoma. But when it comes to biologicals, the data we have, the most robust data, come from the rheumatoid arthritis literature, mainly because they have been using biological agents for longer as compared to psoriasis. And in this meta-analysis, which was performed by the group of Xavier Mariette in Paris, they found that the use of TNF inhibitors was associated with a small increased risk of non-melanoma skin cancer. But in their work, they didn't find that the use of TNF inhibitors was associated with an increased risk of non-skin cancer. Next slide. So what to do in patients who have a history of cancer? What do the guidelines tell us? Let's look first on this slide at the British Association of Dermatology guidelines. The guidelines say biologic therapy should be avoided in patients with a current or recent past history of malignancy, unless the malignancy has been diagnosed and treated more than 5 years previously, or where the likelihood of cure is high. The European guidelines tell us that malignancies or lymphoproliferative disorders are relative contraindications. Of course, with these guidelines, it's not easy to satisfy all patients, and they need an update. Next slide. On this slide, you have the proposal that will be discussed for the European guidelines in the next few months. And the proposal is really to tailor the use of treatment according to the individual patients. Of course, the first statement is that the most appropriate treatment for patients with a recent malignancy include topical therapy, phototherapy, except if the patient has skin cancer, and acitretin. Second statement that immunosuppressive therapies, especially cyclosporine and biological agents, may be associated with impaired immunosurveillance. The role of methotrexate and fumaric acid is less clear in this respect. Third statement, the decision to initiate immunosuppressive therapy in psoriasis patients with a current or recent history of cancer in the previous 5 years should be discussed on a case-by-case in collaboration with a cancer specialist. And an informed decision should be reached respecting the patient's preference. You see, this is the first guideline where the notion of patient preference, patient shared decision is included, which to my opinion is a very important point. It's not the physician alone who's taking the decision. It's a collaboration between the physician, the patient, and other specialists. The elements to be taken into account for the shared decisions are the type and staging of cancer, the risk of recurrence, and the burden of psoriasis in the individual patients. In some cancer with relatively good prognosis, where flare of psoriasis cannot be controlled by alternative therapies, earlier introduction of immunosuppressive therapies may be considered, in this case, methotrexate should be the preferred agent to use. So in patients who have a history of cancer, when there is a need to start a systemic treatment, methotrexate is clearly the drug of choice. Next slide. So this slide summarizes the points we've discussed in this chapter. In patients with cancer risk, methotrexate and acitretin are the first systemic agents to be used. There needs to be a caution with TNF antagonist IL-12/23 and IL-17, and cyclosporine has to be avoided, and phototherapy has to be avoided if the patients have a history of skin cancer. Next slide. Now let's look at chronic infection and age in this last part of the presentation. Next slide. So we are speaking about the treatment of psoriasis in patients who have a higher risk of infectious complications. First, let's discuss about elderly patients. So it's clear that elderly patients over 65, 70 years of age, have a higher incidence of bacterial infection, have a higher incidence of viral infection, mainly zoster. They may have been exposed to tuberculosis in the youth, and they have a higher risk of latent tuberculosis, and they have impaired immunosurveillance. These patients also have reduced glomerular filtration rate and reduced liver function, which means that they may be exposed to higher doses of drug and have higher exposure of the drug. So these patients form a population in whom we have to be particularly vigilant regarding the use of immunosuppressive agents, and we should avoid high doses and long durations of treatment with high immunosuppressive agents. Patients with chronic hepatitis, hepatitis B and hepatitis C are very prevalent in some countries, and these patients deserve specific measures. And last but not least, especially with anti-TNF agents, we have to be vigilant to patients with latent tuberculosis. Next slide. Let's start with hepatitis B. Hepatitis B may be reactivated in patients who receive immunosuppressive therapy. On this slide, which was provided to me by Professor Laurent Alric, a pathologist from Toulouse, he shows that patients with chronic hepatitis B, which are detected with hepatitis B serology, these patients may have hepatitis B reactivation with immunosuppressive treatment, methotrexate, anti-TNF, rituximab, and chemotherapy. Very important point. In patients who don't have HBs antigen, but who have only anti-HBC antibodies, you may consider these patients as not having chronic hepatitis B, but these patients may have hepatitis B and may have hepatitis B reactivation. So in patients with anti-HBC antibodies without antigen HBs, you need to be vigilant because depending on the immunosuppressive treatment, they may experience hepatitis B reactivation. Next slide. So, in summary, for hepatitis B, it is recommended to screen patients for hepatitis B using both HBs antigen and HBC antibodies, and to do that before methotrexate and biological treatment. Hepatitis B reactivation is rare but possible. It has been discussed and shown with ustekinumab and infliximab. You can refer the patient to the hepatologist for antiviral treatment before starting a biological agent or a systemic treatment. and it's important in these patients to monitor transaminase and HBV DNA every 3 months. For hepatitis C patients, the risk of reactivation is not significant with biological agents and methotrexate, but it's important to check for the presence of liver fibrosis before prescribing methotrexate in these patients. You can refer the patient for the hepatologist for staging of the hepatitis C, and it's also important in these patients to monitor HCV RNA and serum transaminase every 3 months when you start a biological agent or a systemic treatment. Next slide. In these patients, the preferred options are acitretin, phototherapy, and etanercept. You need caution with cyclosporine, methotrexate, adalimumab, and ustekinumab. And infliximab, which is the most suppressive anti-TNF agent, needs to be avoided. Next slide. Let's speak about the risk of tuberculosis. The high risk of tuberculosis in patients who have latent tuberculosis is mainly an issue which is prevalent with anti-TNF agent. For detection of tuberculosis, local guidelines need to be applied. In France, we do the quantiferon, and we do the quantiferon before initiating systemic treatment and biological agents. The risk of tuberculosis reactivations is the most important with infliximab. After infliximab will come adalimumab, and the risk is less with etanercept. So in high-risk patients, or in patients who have a high risk of contamination, the healthcare worker, the people who are travelers in endemic areas, or the social workers who are working with homeless or prisoners, these people probably you will need to prefer traditional systemic agents or use ustekinumab before using anti-TNF agents. Next slide. This comes a conclusion of this presentation. In summary, we can say that there is a need for a better evaluation of the efficacy and the safety of therapeutic agents in psoriasis, especially in these vulnerable populations with comorbidities. Point 2, the tendency to reduce the inclusion criteria in clinical trials impairs the benefit-risk evaluation of your new drugs and impairs the generalizability of the finding to the population of patients we treat. There is limited information about patients with comorbidities in the literature and in the guidelines, but this will certainly improve in the next few years. Age, older age, history of cancer, infection, and cardiovascular disease represent important factors which influence treatment choice in psoriasis. Thank you very much.